Okay, good afternoon, everybody. We'll call this meeting of the Health and Human Services Committee to order. And I think we have one bill that's been pulled until next week. That would be Senate Bill 216. The parties have asked that that be held to next week. So we will not be hearing that one today. It's my understanding that Senator Unterman is still in committee. Is that what some of the health people, are y'all watching both of them? That she's still in committee and going? Okay, so I will call Senator Bethel for Senate Bill 85. Senator Bethel, you'll give us the form on that, which the number on it. I don't have a preference, Senator. Help whichever where you're more comfortable.
Thank you very much, Madam Chair. I am working from.
Keep you on him on. I think you're going to have to get a little closer to the mic.
Let me see. Is that better? Thank you.
A little bit better.
I'm working from the as-passed version of Senate Bill 85, which should be LC 335097S, which was a committee substitute in the Senate Health Committee. I appreciate the Chair's flexibility. It is that season, and as I've indicated, the Chair, I have other committees to attend to, and so I appreciate that I will stay as long as possible, but I know there'll be testimony on this bill.
Right.
Senate Bill 85 is built on current law as it relates to immunizations for influenza in Georgia in a pharmacy setting. For those of you who are longtime members of this committee, this was Senate Bill 288 last year. We passed it out 43-7 and then 46-7 this year, and the substantive provisions have not changed dramatically, but I'll try to walk through the bill as expeditiously as I can, Madam Chair, and then reserve time for questions. The most of the striking in the bill is actually striking the word influenza, because as I said, we're building it on the platform that's already in Georgia law for physicians to give flu shots under a physician's protocol. And what that looks like is for receiving an immunization in Georgia, there are a couple of ways that can happen. The first is a doctor can give a prescription and then administer the vaccine in their office. They can send the patient to the pharmacy with the prescription, and the pharmacist can administer at the pharmacy. They can also go to the county health department or the Department of Public Health and receive vaccinations in that setting without a prescription, subject to standing orders that are issued for the county health department. And then for the flu vaccine, they can go to the pharmacist and receive a vaccination under a physician protocol agreement, which means a physician that lives in the health district where the pharmacy is located has signed an agreement with that pharmacy authorizing the administration of the vaccine if it meets certain criteria. We would ask that that provision be expanded to include other vaccines. As we sit here today, there are 38 states in the United States that allow all CDC recommended vaccines to be administered by pharmacists under, well, some are not even under a physician protocol, but by pharmacists for all adults and adolescents. So we would be not joining them because we only address adults in this legislation, and we don't include the entire CDC suggested panel of vaccines. So, turning to the substance of the bill itself, you will see that the beginning parts of the legislation that are before you are definitional and essentially striking the influenza language and leaving it as vaccine. We define vaccine in the Act specifically in terms of the actual disease states that they are intended to treat. And so these are the CDC recommended vaccines for adults, excluding the HPV vaccine. That's the one that would not be on our list there. We have added, this is new from the bill that I presented this committee last year, on line 127, a new paragraph 5 This is intended to ensure that we are respectful of patients with medical homes that are in a physician's practice. This requires that if the vaccine recipient requests, and the pharmacist must make it available to the patient, if they request notification to their primary care physician, that notice must be made. Currently, they are required to upload it into the GRIT system, which is our database, which physicians and pharmacists and health departments alike are required to put notice out there, and then they can access that information when they're dealing with any patient who's in front of them. But this would add a step of saying if you want specific notification to your primary care physician, that it would be provided. Madam Chair, as I turn through the bill, the only other substantive change from the bill we presented last year, it deals with, I want to say correction, by addressing the age issue. Last year we inadvertently eliminated pharmacists' ability, had last year's bill passed, inadvertently eliminated a pharmacist's ability to give the flu vaccine to individuals over 13. And so you will see on page 7, lines 218 through 220, the correction there that says the flu vaccine, if this passed, would be administered as it is today under the protocol to folks over 13. But for all other vaccines, it would be for individuals 18 years of age and older. The benefits are sort of, I characterize them in 3 areas. Number 1, this is an increase in access to care, particularly in rural Georgia, where it sometimes can be a greater burden to get into a physician's office or another delivery system for vaccines, so that people have an easier access to care. It improves public health by increasing the vaccination rate. Even just last month, the Centers for Disease Prevention and Control, or Control and Prevention, issued a report bemoaning the low adult vaccination rates in the United States. And then it lowers the cost of health care. It does so in 2 ways. One, through the increased public health, because it's a goal that we have to increase appropriate vaccination rates. And so people who've been vaccinated are generally healthier and cost us all less within the healthcare system. And then the actual transactional delivery system is a lower cost to payers, patients alike, whether that be the patient himself or an insurance model. How does this look? How does this actually look for real Georgians? The clearest example is that TRICARE, which of course insures our military families in Georgia, has adopted a policy that in states where this is permissible, where a pharmacist can administer vaccines through a protocol agreement, a TRICARE member does not have to pay a copay in the pharmacy setting for their vaccine when it's, again, appropriate. So immediately upon passage of Senate Bill 85, every TRICARE member has an immediate economic benefit in that their appropriate vaccines go to $0 in terms of their transactional cost. Obviously, they're paying premiums and whatnot. So that's a real direct savings. I do want to thank the chair for being very open and working with me on this bill, and Chairman Underman, who will certainly be here shortly. She convened a stakeholder meeting. Probably a lot of the folks that you will hear testify on this bill later were invited to a meeting with the chair, Chairman Underman, and to talk about this very issue, because it's certainly an issue that folks have strong feelings about. With that, Madam Chair, I'd certainly yield for questions, and as I may.
Before I go to the committee, I'm sure it was just a mistake that you said, and in the pressure of presenting a bill, that 32 states allow pharmacists to give all of these, the things recommended by the CDC. And that is, if you have the research on that, because my research analyst has been researching that, and that is definitely not the case.
Well, Chairman, what I actually said was 38. So if I will be glad to be corrected by facts as your researcher has found them. The information as has been presented to me, and I won't read them. I mean, there's no
Right.
reason to read 38 states, but I have the list. I'll be glad to submit it, that these 38 states allow pharmacists to administer all CDC-recommended vaccines. That is to say, not recommended for international travel,
No.
but recommended for adults in the United States. And I'd be glad to give it to the chair.
I-
This is the data I'm working from, so
Well, Senator, thank you, but I will tell the committee that I have been working, and our researchers have been looking at all of the individual states, and that is not the case, Senator. There are different varieties, and so
well, we're doing a hearing today, so I'll make sure we've done our homework and document what this is based on to the chair and to the committee.
thank you. I mean, I'm sure it was
Sure,
just an
absolutely.
oversight in states that allow any or one or two of the vaccines. They come with different caveats on them. Like some states will allow something to be given only in areas where they're low served and all. So there's various caveats on all of these. So
We'll try to make sure we're all singing from the same music.
thank you, Senator, on that. Okay, questions from the committee? Okay, Representative Watson.
Thanks, Senator Bethel. We certainly have had discussions on this in the past, and I appreciate your forthright nature. The TRICARE copay, I'm glad to see that they have adopted the no copay for pharmacists, because that is actually what the copay is. No copay for my office for TRICARE also. So I'm glad to see that they'll both see cost savings with that. So I'm a little concerned, with the philosophical point of view of health care and patients. That's sort of what I think is the most important aspect of this. The medical home, which is what is driving health care now based on quality, cost reduction, and so forth. And to me, this fragments care. And the way this fragments care, not only does it keep it out of the medical home or the primary care physician, and actually does not encourage the patients to get care in their primary care, which is I mean, listen, I practice medicine in Savannah, but sometimes I practice medicine here in the capital, and getting patients to go to their primary care physician is not always the easiest thing to do. Now, vaccinations are not a major source of revenue for a physician's practice. In pharmacies, I mean, I know that Sam's Club and Walmart's and charge $4 to get the patient into the store. Where 5 years ago, the Wall Street Journal reported they spent over $70 for that. My perspective on this is that wellness visits, and I don't know how recent your data is, but wellness visits by Medicare cost the patient how much?
By Medicare?
Medicare wellness visits cost the patient?
I don't know what a
Zero. Okay, and when they come in for the wellness visit, what are they updated on?
It depends on the physician.
No, it's a checklist. If you want to get paid, you're going to check it. So we're updated on colonoscopies, mammograms, and vaccinations, one of them, and the list goes on. And it's a pretty exhaustive list. So the patient's paying nothing for this wellness visit, pays nothing for the copay for the vaccine. So how's it going to save them money?
For the Medicare patient,
No, well, if you want to bring up the private insurer also, we can discuss that then too. But we're going to come to that.
this is the data that's available.
No, I'm talking about 2013 now, 2012 actually also.
Yes, sir. This is the data that's available in the congressional record from the TRICARE issue.
Okay.
When TRICARE adopted their policy of going to $0 copay.
Now we're switching TRICARE to Medicare is what we're doing. Okay, we'll just talk about Medicare first. We'll come to TRICARE.
I don't have Medicare data that's validated in the
Well, I will tell you,
record.
it is zero wellness visit for the Medicare patient.
Yes, sir.
It is zero for the copay. Let's talk about Blue Cross Blue Shield, United Healthcare in the state of Georgia.
Yes, sir.
Wellness visit?
I would assume that that's $0.
It is. Copay for vaccines?
I would assume that was $0.
You're exactly right.
Yes.
And So let's bring up TRICARE.
Okay.
Maybe your data is different, but certainly in my office, the wellness visit is zero. The copay for TRICARE is zero.
What's reflected by their data is that in 6 months they saved $1.5 million. And so whether that's coming as an injection cost, whether it's coming in just Georgia or wherever else, what I can also
And
say,
the year on that was?
it's 18 months. So that would be
Okay.
2012. 2012, I guess that data would be associated with. What we can say is that the CDC has said our vaccination rate is too low. And if Medicare...
Well, let's talk about the vaccination rate then. I mean, and they're getting that data from where?
themselves.
All right, and that vaccination data comes from
Various sources.
the GRIT system.
Well, in Georgia, it would come from GRIT.
No,
from various
no,
sources
no.
nationwide.
The GRIT system originated where?
It's the Georgia Registry of
It
Immunization.
originated in Savannah, Georgia. It was a pilot program several years ago. It spread to the state of Georgia,
Yes.
and from there it spread to the United States. You know, it's interesting, you know, if that data is coming from there, you know, I have patients in my office that come in and get their vaccines, and I have patients where, as your bill suggests, that they get pieces of paper that are faxed to us. You know, last year, you know, everyone I'm entered in the GRIT system and so forth. I did sort of a random sample of patients. I said, well, let's sort of check it out. Let's see if it is. Ours are, and you know, half the pharmacists, about 50%, were entering it into the GRIT system, or not. That's not a real good vaccination report.
How did you do your sample?
We looked up the patient. We took the sheets of paper that we got from the pharmacy. We looked up the patient in the GRIT system and whether or not it was recorded.
Okay.
Interestingly, Dr. Jacqueline Fincher, who's also an internal medicine doctor, was past president ACP. She did the same thing in her town, about the same amount of data. Again, I think it goes to the philosophical point of quality of care, and that's the main issue with me. It is a medical home, is what we're doing, hopefully to drive down the cost of health care, and to fragment that is not, hopefully not what we're trying to do.
Well, thank you, Doctor, and I would agree that would not be a good goal. As a plan administrator in my day job, so to speak, my rest of the year job, we certainly advocate a medical home, and we don't have a copay for a well visit nor for vaccinations. What I would observe on the medical home piece is that from our standpoint as a plan, we try to drive at least at a minimum an annual well visit. The prescription, the vaccine rather, that is given on an annual basis is the flu vaccine, and we already allow it to be administered in a pharmaceutical setting. These other vaccines are multi-year interval, and sometimes much longer than that, depending on the efficaciousness of the vaccine, how long we stay immune. If we're trying to drive folks to their primary care physician every 3, 5, 10 years, we've got to find better ways to get folks into their primary care physician than using the vaccine. I would say.
It's just a piece of the puzzle.
I understand that.
Representative Sharper.
Thank you, Madam Chair. When I look at this, I'm looking at, for one, from a time and energy standpoint and a liability standpoint from the pharmacist. Already we know that the pharmacist has a lot to do anyway, but when we're talking about these vaccines, even though you have a small amount of side effects, but when something does happen in that particular pharmacy or Walmart, wherever they are, and there's a situation that arises, that means, for one, that pharmacist is going to have to stop everything they're doing, call 911, even though the pharmacist may not be able to really do much for that patient. They're going to have to sit there and stop until this patient is taken care of. All right, another thing I look at is that GRITS database, like he's saying. A lot of the pharmacists, they don't really have time to even I would say, to look up in the grid system, find out what's going on with this patient, and then you got to look at the medical records and see what this patient, what's going on with this. So therefore, I think if something like this does pass and you have this long list of things that they can do, when is it going to end? What is going to be next? You know what I mean? Now the pharmacist is going to be doing a whole lot more, which is taking up more time and energy, and like I say, the liability. And I was just wondering if there's anybody here with the health department, anybody here representing the Georgia health departments that you know of, Chairman?
We had somebody earlier with public health. We do.
Okay, because I don't know if this is the time to ask them, but I'm wondering what is their take on being that the health departments do a lot of the, a lot of these immunizations. How is it going to really affect them, and financially, how is it going to affect them, being that the state does some funding for the health, community health? How does this play in with them? People going elsewhere to get these immunizations.
Would you like to answer that question now? Come forward and identify yourself, and you can go to this mic over here if you want to at the podium. We've got Representative Senator Bethel isolated down there. Just teasing. Boy, it just almost made you a doctor and a rep and
I'm not that.
slip in there.
My name is David Bain. I work for the Department of Public Health as their Government Relations Director.
Okay, you want my question now?
Yeah.
Okay, when it comes down the grid system as well as the financial aspect of someone else, the pharmacist doing a lot of these immunizations versus you guys doing it, how does it play in financially, for one?
It's something that we haven't looked heavily into in terms of the impact across the state for us. I think our take has been that one of our major goals is to make sure that our populations get immunized one way or another. And so it's been less about the financial part for us and more about the folks getting vaccinated. Having said that, we understand this is a complex issue, and so we're not taking a stand on this bill and saying this is a great bill or a terrible bill either way. We recognize it's complex, but from our perspective, we're trying to make sure that folks are getting immunized. So that's our primary concern, is not the financial end of that.
Okay, so when it comes down to the database side of it, if the pharmacist can do 100% great job of putting things in the grid system, that's going to help you because you know what's going on.
Yes.
However, if they're not doing a proper job with the database and putting it in the grid system, then that may give us a false sense of how many people are actually getting immunized.
It'd be problematic, yes.
Okay.
Representative Sharper, I think I can answer one of your questions on it. I know that the public health in Gwinnett County is aggressively trying to get people to get their vaccines, and it is a very financial positive for them by giving these vaccines.
Okay.
Even though they're given at a reduced rates, and for people, they do find that to be to a financial advantage for their department. And somebody else called today, and I can't remember which county it was, and said the same thing. So it was a smaller county. I'm sorry, I can't bring up that information right now.
Okay, so what we're saying possibly in this, just still in looking at it, so if we have several counties that are affected by this, and then their income is down, so that kind of affects us as a state to have to find more money for them or some type of systems.
Again, I want to be clear. The impact for us has not been made certain, so I don't want to make sure that we don't have an official statement about the impact. It's still something we're looking into.
Okay.
Good.
Thank you very much. Representative Pruitt.
I believe that's 26, Representative Kaiser.
Oh, sorry. Representative Kaiser.
Thank you, Madam Chairwoman. Senator Albers, I can't see you, but
No.
hello.
Now,
Senator Bethel. Uh-oh, sorry about that. I was looking at the
there's a lot of
second.
things I can be called.
I apologize.
I think he'd rather be called a representative or a doctor. But
Okay, well, how about this? It's a friendly question. Does that help? Okay.
That's fine.
I've read the bill. I thought I understood the bill, but now that the discourse between my friend to my left and you is a little confusing. So you're the only one that can speak to the intent of this bill. So could you speak to tell me if I'm right. My understanding is that this really is still in the control of the physician.
That's correct.
So the physician is the one who comes into an agreement with the pharmacist. The patient's notified about the agreement. So I'm just confused. I didn't really come into the committee with large concerns about the bill. I look at it, I see it like this, and tell me if I'm right or not, and the doctor, if you would speak to it as well. So if I go to my physician and I, God forbid, am told that I have, say, I don't know, I'm HIV positive, and I have to have a series of vaccinations, my doctor can say, well, I would like to come into an agreement with your pharmacist who is around the corner from your home, and you can be vaccinated regularly without having to go back to your doctor. Is that not?
No, ma'am. The bill contemplates the same way we do the flu vaccine today.
Right.
A physician in Georgia enters into an agreement with the pharmacist independent of any individual patient. That is to say, they enter into an agreement with an immunizing pharmacist, and Representative Sharper, your question earlier, I think, raises this question, so I'll try to get both. An immunizing pharmacist is someone who's had 18 hours of continuing education. They have to have an EpiPen on site. There's a lot of criteria set out for them to become an immunizing pharmacist. I would offer that in terms of the time responsibilities, my friend Dr. Watson is just as busy as any pharmacist when he's practicing medicine in his office, and the demands on his time, I know from a distance the world they live in terms of transactional turnover. Everybody in healthcare is extremely busy and overtaxed, but they do have to have that agreement in place. And I would offer, in terms of the liability piece, one is that pharmacists carry professional liability insurance. So do pharmacies, that is, say, companies that are in that business. And sort of, I guess, an ancillary piece of that is that most adult vaccines in Georgia are given outside of a physician's office. Most of them are actually given in the county health department. That is to say, the most numerous. So they're not. That is not a location that we have designated as sort of like a sacrosanct location for a vaccine to be given.
Okay, thank you. Representative Kaiser.
I just want to know if you would follow up. Would you speak a little more specific to what it means when you say, because this is where I'm misreading or misinterpreting the intent. Could you talk a little bit further to, and I'm sorry I was late, Madam Chairwoman, but
We haven't covered it.
for a group of patients who meet certain criteria?
Yeah, I'm looking.
I'm sorry, on line 49, page 2.
Yes. The protocol agreement would specify on the physician's part what the pharmacist had to ask, know, understand, in order to be authorized to give the vaccine. Now, I am not a doctor of law, maybe, but that's not counting in this committee. But
Wrong thing.
But that's right. But I don't want to misstate. I don't want to misstate the state of the practice of medicine, so Dr. Watson can correct this. I would liken it to standing orders. It's not necessarily the same thing, but in other words, the doctor has said if a patient presents with ABC and XYZ, then you're authorized to give them this. Otherwise, no. Otherwise, you've essentially engaged in the unauthorized practice of medicine in Georgia, which is against the law. So you have to follow the directions of the physician, but you don't have to have a unique prescription for that individual patient if you've done your due diligence in preparation.
Well, actually, my seatmate, if I could follow up, so you don't have to call another person, asked if you would just give us an example.
The flu vaccine today, and my own representative is sitting right in front of me, and he'll correct me if I'm wrong, Representative Broderick. But the flu vaccine today, if you go in, the pharmacist has a series of questions that are built by the physician in terms of the physician protocol agreement. And so they answer those questions, and it's similar to the checklist that Dr. Watson described in terms of getting paid on Medicare. I mean, you follow the protocol agreement. So are you, for example, are you expecting a child? If you are pregnant, then most, if not all, vaccines will be counterindicated because sometimes there's heavy metals and all this kind of stuff. There will be reasons why you would not want to give a pregnant woman a vaccine, and on down the list. How old are you? When was the last time you got I mean, you do a workup, so to speak, and then if you fit in the approved category according to the physician that you're working with, you give the vaccine.
Okay. All right. Senator Bethel, in following up on Representative Kaiser's question, first of all, there's nothing in the bill that says the person writing that protocol should be an internist or a family practitioner. It could be a neurosurgeon writing protocol, or it could be an orthopedic hand surgeon writing the bill, somebody who's not right. Is that correct?
That's my understanding. Every physician who would be authorized to give a vaccine in Georgia would be able to, as my understanding, would be able to approve a protocol. That is to say, all those same physicians are able to give vaccines now, so they would be able to approve a protocol.
But some of them might be very unlikely to have given a vaccine in the last 30 years. And also, so what we're also saying is that the bill would mean there would be possibly hundreds, if not close to 1,000, different protocols across the state.
There could be a large number, no doubt about that.
As big as our state is, with 10 million people, there could be probably 1,000 different protocols across the state with no parameter set or any kind of a guideline to follow, right?
And if this committee felt like there should be a uniform protocol agreement that puts parameters on it, I would be open to that discussion. We built it on the same platform that this body passed for the flu vaccine, which was a protocol agreement with a physician in your health district. But if in all seriousness, if that is an issue that the committee thinks makes the bill stronger, I'm open to that discussion.
I'm just asking the way
Yes.
that, and then before we go on, I'm not sure how long you've been here. Do you remember when we gave pharmacists the right to be able to give the flu vaccine?
Flu vaccine I don't remember independently, but I know folks in the room. It was the flu outbreak of 09?
Right.
09?
Okay. Well,
Somebody
the year,
who comes after me will
the
know the
year is
answer to
not
that.
exactly as important
That's
as. Do you remember why?
There was a shortage of vaccine and an outbreak of flu.
There was the threat of a very serious type thing, and it was given, not because people felt like that people were not getting their vaccines, but there was felt like there could be a crisis across the state, which didn't pan out to be, but that was what prompted the legislature to do it in sort of an emergency situation, correct?
The H1N1, yeah.
Right.
And now we have outbreaks of whooping cough in Georgia and other.
Are you saying that everybody should get a whooping cough?
Of course not.
Okay.
But those that the CDC suggests should.
It's not for everybody. Okay. What, Representative Randall? Okay.
Thank you, Madam Chair. Senator, I have a couple of reservations about the bill, and I want to just kind of run some things by you. Without any standard protocol or guidelines for this, that makes me a little nervous. There are some of the larger pharmacy chains, not my friends Representative Stevenson or Senator Carter, that have smaller, more privately owned businesses, but the big boys, the ones that usually build right across from each other on either corner, and I happen to have a pharmacist in my family, and who and the way things have changed in pharmacy, you have less pharmacists working, a whole lot more techs working, and the volume that they are expected to maintain in those hours that they do work, it's a madhouse. Even some of the grocery store pharmacists are, taking time off, stress. I mean, it's crazy. And I'm just afraid that if this is built into their regular daily routine, I'm not sure how thorough they can be, especially without standard protocol or guidelines. That worries me.
Okay.
The other thing is, had you considered perhaps like maybe doing a clinic time, like if they knew at this particular time you can go to this big pharmacy and that's when they do immunizations. I think that would slow down the pace, not that I'm still comfortable with it, but I think that would slow down the pace. It would give them concentration on one thing at a time, and those, maybe 1 hour on Tuesday morning or something like that. I don't know if you've ever considered something like that, but I want to be comfortable with, I know the convenience of it for a lot of people would be fantastic. But I'm just a little worried about a couple of those things, if you'll address them.
Thank you, Representative. Well, I think you and I share concern for the workload of all in the healthcare profession. That is to say, it's not just in the pharmacy. It's happening in doctors' offices and other settings as well, that the demand for their time is such that it's very stressful. As I indicated earlier, if we want to have a discussion around some sort of standardization piece to the protocol agreement, I am open to that discussion. That is to say, if the General Assembly would like for there to be a uniform standard, then that's fine. We don't have one now for the flu vaccine. As far as what their demands are now, I would just point out that they're authorized to do this now just with a prescription. That is to say, no, ma'am. They can do all of these vaccines with a prescription. We're just talking about that step where the visit to the doctor's office and obtaining a prescription is required before you go. A lot of these are done at the county health departments. Vaccines like shingles, for the most part, are done in the pharmacy setting because the shingles vaccine is very expensive and it has a very short shelf life. So it doesn't make sense for most doctors to keep it in stock because they don't give it so frequently. So they give a prescription, you go down, multiple doctors are feeding into one pharmacy. So they're already authorized to give all of these vaccines pursuant to a prescription. Now, as for the question of a clinic time or designated time, if we're looking at a uniform protocol and we want to limit the times, my only concern is for people who have irregular work schedules, we're picking a time that sounds convenient to us. We may not be responding to working Georgians and what's time most convenient to them. So I'll be hesitant to sort of designate a statewide. But I would think that physicians, if they had those concerns, could work that into a protocol agreement that says you're authorized to do this under these times and at this time of day, under these circumstances, this time of day, to protect the pharmacy setting and to protect. So I would think that would be an available option for a physician to go down, even if we didn't put it into a standard protocol agreement.
Follow up on the representative's question and her concern about the patients getting them. Yes, the pharmacist can now, with a prescription, give things for the shingles, but with a prescription, the patient has seen the physician, and the physician knows whether the patient is HIV positive or whether they are on cancer treatment or have other contraindications. Is that not the difference? Is that they know that and know the patient, and it's a specific prescription with the physician knowing what's happening and sending them because, like you say, the vaccines, some of them are very expensive with short life.
That's yes.
Because that's the difference.
Yes.
Thank you. Representative Kidd, you pass. Representative Pruitt.
Chair, I've been talking a lot and listening a lot, and I probably missed a few things along the way. But the question would be, would there be an opportunity here for a doctor to decide on his own whether or not this is something that they individually could decide they wanted to go down this protocol and choose?
Without the legislation?
No, with the legislation, or is it in this legislation clear now that a doctor could or could not, based on his own beliefs, decide whether or not he wants to enter into an agreement with
That's correct. There's no requirement that a physician execute an agreement with the pharmacy.
But it's totally up to the individual doctor. Some may, some may not.
That's correct. But understand, I want to be transparent on this. If one doctor that lives in that health district, it's not as though your doctor would be able to say, Representative Pruitt is under my guidelines. The physician would enter into the protocol agreement with the pharmacist, and then any patient that went into the pharmacy that met the protocol agreement's criteria could have the vaccine.
They do not have to be that particular doctor's patient.
Does not have to be your primary care physician. That's correct.
Representative Pruitt, I think you're talking of, unless they have changed it since last year, and I looked at this bill, Arkansas had that kind of provision, and their law said that if a physician entered into a protocol with one pharmacist, that they could do that. But like if they enter into that protocol with one pharmacist, when that pharmacist left the the pharmacy, then that did not go to anybody else. So that was what type that Arkansas did. Now, I have not checked Arkansas since last year, but I will. But that was what, when I talked to them on the telephone, Arkansas tried to explain to me. So about what you're talking about. Representative Clark.
Thank you, Madam Chair. Senator Bethel.
Where'd you go? Oh, heard your name and I didn't see you. Sorry.
3 questions for you, and I'll just throw them out there real quick and then let you address them if you will. The argument, could you just elaborate on the argument of why the Department of Community Health is able to administer these but a pharmacist cannot? I don't understand that real well, but what is the secondly, okay. Public what did I say? Thank you, public health. And then if we're not allowing pharmacists to prescribe these vaccines to children under the age of 18 except for the influenza, what percentage of the vaccines are going to the population that's over the age of 18? And lastly, my wife's grandfather talks a lot about, he's a surgeon, a second generation. He talks a lot about the doctor-patient relationship and how he feels like patients are being, in current health care, oftentimes being rushed through an assembly line, and that they're not getting as much care as a doctor would like to be able to provide, oversight and all. So I guess the question is, how many doctors, I hear Dr. Watson's concerns, but what are you've carried this bill now for a couple of years, what are you hearing from doctors? Are they in favor of this or not? I would feel like that they wouldn't be, but... Well,
okay. I'll try and get these sequentially if I can. The question about the Department of Public Health, I don't see a dramatic difference in what I understand most county health department, public health department does in terms of administering vaccine. That's where I go, frankly, to get my vaccines, is my county health department. So I don't see a significant difference in the state of the practice. I've never seen a physician in the county health department. It's always been one of the nurses on staff. They ask me the questions, they give me the vaccine. So I'm sure other people have a different perspective on that, so I don't want to diminish other people's perspective. I just want to take that's just my answer. Mm-hmm. Adult versus infant vaccines, obviously the overwhelming majority of vaccines administered are infant vaccines. However, there is a growing share of adult vaccines. Not a whole lot of vaccines are given through those adolescent years. I don't have the statistics at my fingertips. I will get them to you, Representative Clark, in terms of numbers. They do track that. But I'll try and get those to you as quickly as I'm able. But there are a significant number of adult vaccines that are administered. And then as far as the physician community, Medical Association of Georgia opposes this bill. They have since I dropped it, actually in 2011. I did it after crossover day so I could have discussion. So to be clear, they do. And the American College of Physicians opposes the legislation. There are no other organized doctors groups that I'm aware of that oppose the legislation. Family Physicians of Georgia has actually taken a position in support of the legislation. And I can speak only for the doctors I interact with on a regular basis in my community. When my hometown paper ran the story, my children play sports with a lot of doctors' kids, I got nothing but positive comments from them at the ball fields, that they want their patients vaccinated. They want to increase it. As Dr. Watson said, their perception is that this is not a large revenue driver for them. They don't view it that way, and they want their patients vaccinated. They want them healthier, and they're pro-increased vaccination. But that's not the position of I want to be clear. Medical Association of Georgia opposes it. American College of Physicians opposes it, and I respect them. I have 2 uncles who are physicians, and they happen to be for it, but they're biased. So,
And
I guess my question was, and I guess you've answered that perhaps, but if a majority of doctors would feel like that would infringe upon their doctor-patient relationship and having control over, control and oversight, if they felt like that was relinquishing it, then I wondered how many of them would, even if we passed this, would sign that protocol. But you're thinking that there's significant?
I would say in rural, we've signed them for the flu vaccine in every health district that I'm aware of. I don't know of any that doesn't allow it. So I would think you'd be able to find physicians that would. If you wouldn't, I mean, then that would be something that the industry would have to do. I do think that the major objections are real objections. I mean, that is to say, medical home is a real issue, and scope of practice is a real. I mean, I'm not by any means trying to say. I just have a difference of opinion as to where this fits in the spectrum of appropriateness, and it's driven primarily and in all candor by being a plan administrator on a health plan.
So that's money and the cost. Is that it? Correct, Senator Bethel?
We can vaccinate 5 times as many people for the same amount of money today, or the same amount of people for 1/5 the cost. And we talk so much about the increased cost of health care and wherever you feel on the Affordable Care Act. That's not the issue today. But we talk about all the things that drive the cost up, and this is a demonstrable way to drive the cost down, both not just at the transaction level, but with increased vaccination, which should be all of our goals when it's appropriate. Now, inappropriate vaccination, I'm not talking about that. I'm talking about appropriate vaccination rates are good for all of our communities. And I want to make them more available at a lower cost. That is the end story here. And I think there's enough patient protection from my perspective. And other people, I mean, Dr. Watts, that's my friend. I mean, we hang out, and he disagrees with me. And that is okay. That is how this process, we've had this conversation before, that is how this process is supposed to work. It's okay.
So, Senator Bethel, you're saying your main concern as a plan manager is the cost?
No, ma'am.
I thought that's what you just said.
My reason is because there's a way for us to vaccinate more people with less money.
Well,
my purpose is increased vaccination of adults in Georgia.
okay, but I thought that the reason that we are so low as far as states in being at our vaccination rate is because we have such a problem with children not being. And that is what skews us down to a lower thing, and this excludes children. And I believe that's what it does.
Madam Chair, I mean, I understand that we are low on childhood vaccination, but our adult vaccination coverage is also low, nationwide and in Georgia. I mean, this is a national problem. It's not just a Georgia problem of low adult vaccination rates. CDC report just dealt with adult vaccination rates.
Okay.
And we are low in childhood, and we need to get better.
Okay. And Representative Clark, I will tell you that the public health has been in this country for 100 years, and one of its first goals was, when we started getting vaccinations, was to make sure that children and people were vaccinated against things like later on polio and the ones that came along, and that has been their mission. And public health nurses have been giving vaccinations. There are physicians that each public health district has physicians that write the protocol, and I think you would find a difference in the amount of work. One difference would be that a public health nurse would be working with an individual patient in a different kind of setting and not under such a time constraint as a pharmacist trying to do all the other things that they would do in the pharmacist. And I will tell you that the family practice docs, the decision to whether to support or not was a split decision. It passed by 1 vote, and it was not, their membership was not polled, and there are many family practice docs that belong to MAG and do not belong to the family practice group. So it was very controversial in their decision there. So, thank you. Representative Jaspers.
Thank you, Madam Chair. I have a couple of questions, one for the chair and then one for our senator. I've got a publication in my packet, or was on my table, it's food for thought, and there's no identification of who it's from.
Me.
You, okay. I was
Okay.
wondering, I didn't know.
No, because it was what a pharmacist that was in opposition to this bill being expanded came down sorry that it didn't have my name on it. I didn't know for committee I had to do that, but.
Well, I was just curious. It's because it's a very one-sided view, and I just
No,
needed to know.
It was just a pharmacist that came down and went through with me all the things they had to do in a daily practice in
Okay.
a retail pharmacist that some of our members have concerned about, and the workload. I am I also passed out a pharmacist quits over patient safety concerns. This is an article taken from the Pharmacy Times and by Professor Eccles at the University of North Carolina in Chapel Hill, and it was expressing some of the same concerns there. The professor was, as it says up in the first part that's not in parentheses, saying that he was excited about the opportunity to see expansion, but this was an email that was sent to him by a pharmacist that had some of the same concerns that's on that piece of paper.
Well, yes, ma'am, thank you.
No doubt.
The question I have for Senator Bethel, my senator, good to see you, and then, I was vaccinated for the flu at the Chamber of Commerce meeting in front of 150 people this year, and my pharmacist did it really to promote access. And I think that's what, when I read this bill after lunch today, that's what I was thinking about, was access. And I'd like to hear discussion from the interested parties in this. To the simple question, I think you started to get to just a moment ago, would more vaccinations be done and thereby improve the health of Georgia's people? That's my bottom line question, not the turf war, but how's it affect?
Well, thank you, Representative. Certainly, since the flu vaccine has been available in pharmacy setting, we've seen an increase in the rate of vaccinations overall for adults in Georgia for influenza, and we've seen an increase in those that are administered in pharmacy setting. To be fair, there has also been a greater emphasis in the public, as the chair knows, about getting your flu vaccine. So it's not fair to say that that's just a result of this law that allows us to do it in a pharmacy. That's not a fair assessment. But I think it is at least fair to say it's partially attributable to that. And ultimately, Georgians, unfortunately, we have a lot of adults who don't have a primary care physician, who don't have a medical home at all. I don't want to take anybody who's going to the health department and move them where they're getting a vaccine. I don't want to take anybody who's going to their physician and move them to where they're getting a vaccine. We are trying to reach the ones who are not getting vaccinated today, and they are more frequently in pharmacy settings than they are in the county health department and in their doctor's offices. We want to get them vaccinated when it's appropriate.
Thank you. Okay, Representative Hawkins.
Senator Bethel, I've got a lot of good friends that are pharmacists, and I have the utmost respect for them. I have no question about their knowledge and ability and their heart and their intent. So this question is meant to ask about them. A number of my friends that are pharmacists have been sort of brought into the large groups, different reasons. Some of them, when they were in their independent practice, did not want to do vaccinations. Is this going to cause them any problem if they're in the large box now? Can they say, gee, I don't want to do this, and their job will still be secure? Or do you know?
I don't know. I mean, the answer to your question is I don't know. You have to go through the process of becoming an immunizing pharmacist. So if they're not, I don't know whether an employer would make that a requirement of employment.
Okay. Just food for thought, because I do think a lot of these folks. And the second thing is, on line 2, you could also add dentist if you want to get more access. Martha Phillips, don't fall off the bench back there, please.
Well,
you don't have to answer that, Senator. You don't have to answer that, Senator. I'm not looking to give vaccinations. I saw your tie, dental tie.
Does that get me out of answer?
Yes, it does.
Okay. Representative Beverly.
How you doing, Senator?
I'm well.
Thanks, Madam Chair. 2 quick questions on lines 38 through 42. You added this year. Why those specific?
Well, these are the same vaccines in the sense that we had last year.
Okay.
But they are stated in terms of disease state for a simple reason. We don't want to prefer any vendor. We want to say if you were giving a vaccine to treat influenza or herpes zoster or meningococcal disease, we don't want it to be brand specific. This vaccine and it belongs to this pharmaceutical company or anything like that. We just want to say a vaccine for this disease state.
Okay. Are these the vaccines that if a physician currently writes a prescription for, pharmacists can currently give the vaccine for these particular conditions? Is that correct?
Yeah, all of these vaccines would fit in that category.
Okay. I'm going to switch up for just a second. On line 20 and 21, right? So you have this protocol agreement with the physician. So this thing is set up by protocol. I think we talked about this a little bit earlier, and I just have a little bit of heartburn that I've read through this, and I don't see anywhere where there's a requirement of a case history. Now, maybe I missed it. Is that included in the language of an adverse event? Is that a case history that a pharmacist or a nurse must take in order to? Because so my question is, Charlie, is if you don't have a case history, a thorough case history, and there's contraindication for some of these things. I mean, diphtheria, for instance, right? If you don't have that, then who does the liability flow to? Does it flow to the guy or the girl or the physician who set the protocol? Is it the responsibility of the pharmacist? Who is liable in a space where you give someone a vaccine, well-intended, no case history, something bad goes wrong? Who's liable then if you don't have sort of fundamental things that you have to check off? And I'm not sure that the language... the protocol would suggest the case history.
The physician protocol agreement should, I mean, it would be a question of whether the physician, I think, practiced medicine appropriately. It should specify what the doctor requires the pharmacist to know before administering the vaccine, or to the exclusion of administering the vaccine.
But you wouldn't require, but that's up to the physician to actually set that protocol. It's not a standard of care.
This would go back to the question that was raised earlier, and if it is the will of this committee and the will of the General Assembly to look at putting minimum standards in a protocol agreement, I'm open to that discussion. We didn't do that when we passed the underlying legislation, but if in all seriousness, if we feel like there's a real threat to public health to just simply trusting doctors to set the protocol agreement according to their practice standard of practice, then by all means, let's tell doctors you have to have this in your protocol agreement. That's a discussion we can have.
Well, and to the representative's question, by not listing the vaccines, does this not leave it open to new vaccines being developed for specific thing and them having specific complications and only being administered a certain way, and leave it open that the pharmacist would be able to then administer those without a physician knowing? It leaves it pretty wide open for the development of new things that might have new contraindications and all. If you're saying they're just for the diseases.
Well, it's just for these disease states.
Right, but they might develop new things
to treat these disease states.
Right.
Okay, well, it's a specially prepared antigen, which upon administration will that's...
It could be new ones, new ways, new developments.
That is correct, but then the physician protocol agreement would govern.
But how could a physician anticipate that somebody couldn't give something that was, I guess they could say you can't give anything new and different except the specific. I just don't understand why we would go from being very specific to listing diseases instead. I think that leaves it.
Well, and I understand the chair's, I think I understand at least the chair's issue. Like, for example, now you can get the Tdap, which most people, to tetanus, diphtheria, pertussis. But it is not uncommon now for pertussis to be given a standalone. There was a move at one time to sort of aggregate vaccines, and now there's a sense that that's maybe not the best practice, or in some cases. So you can get pertussis standalone, or you can get tetanus standalone, obviously. So I think there's a sense what we were trying to accomplish in this is to allow for there to be these specific disease states a vaccine, and if you want to give MMR together, or if you want to just give measles, you can give them by itself.
But the pharmacist would be making that decision instead of a physician, instead of an individual physician with an individual patient might have a reason why they shouldn't be given together, or why they should be given singularly.
The protocol agreement would govern what they gave.
But that would be a blanket and not knowing individual patients' needs. Right?
I don't agree with that, but I understand your concern.
Okay. Representative Chokas.
Thank you, Madam Chair. Senator, last year I carried a similar bill, and we talked about it earlier, and I got a copy of the back page, and over 40 representatives signed this legislation last year. Many were on this committee. The question that I have is I've got 2 or 3 of them, and you may have already addressed this, is how many states have this type of availability of vaccines currently?
Representative Chokas, you missed that. The senator said there were 38, and that is incorrect.
We're going to try and get to the bottom of it.
The latest research from our committee research analyst, and from the young lawyer working in my office, and from what I've done myself, there are not 38 states with wide open ability to give all these vaccines. And I don't have an exact number, but it is not anywhere near 38.
Got you. Okay, well, the next question that I have is, at the county health departments, where most of the vaccinations are being made today. For adults. Is it required that a physician provide those vaccines?
It's not.
They work under a protocol.
And the last question, and forgive me for my question about the freshness of the vaccinations. Would they be equally fresh at a pharmacy as at a doctor's office?
Well, I appreciate the question. I don't know that that's a fair. I mean, they should be in date in either location. I wouldn't imagine that a physician in Georgia would give an out-of-date vaccine, at least not intentionally. I mean, mistakes happen everywhere, but yeah.
Thank you.
Representative Pack.
Thank you, Madam Chair. Senator Bethel, quick question. When the state allowed the pharmacists to administer the influenza virus, since that time, have you heard of any cases where they had to call the emergency room because of an adverse reaction?
I have not.
Okay. For those states, no matter if it's 38 or not, something less than that, that expands it beyond the flu shot, have you ever heard of a situation where a pharmacist administered vaccine that resulted in a death or serious bodily harm of anyone who actually got the shot at the pharmacy?
I have not. I haven't done an exhaustive search on that issue, but no, I have not. I will say that last summer, the United States Department of Health and Human Services issued an open letter to the pharmacy community expressing appreciation for their increased work in vaccinations. But I don't know that there's. The answer to your question is no. I have not heard of that, but I don't know whether someone is.
If you had, I would imagine it'd be included in the packet of materials that we have in our folder. The next question I have for you is, I know the doctors are against it, and we've looked at this bill in my short time here several times. Were there any conditions on the bill that they're willing to accept? Or is this just a pure scope of practice, money reimbursement fight?
Mr. Downs is a good friend of mine, and he has definitely talked in good faith, I think, with his board and with me all along. I think the end assessment is there's not a common ground because of the issues we discussed earlier. But I like the folks in MAG. I mean, I do not. They have legitimate, real concerns, and I don't share them in this context based on what I've seen. But I'll leave it at that. I don't want. I just don't want to see it be a bash about that.
Right.
It's about what policy is best for public health, and they have their view of that, and I respect them.
And the Senate passed this, what, 47-7?
46-7.
Thank you.
Okay, Representative Pruitt.
I'm actually the one that carried the influenza bill a few years back, and very conscious of how much help this meant to rural Georgia, where we have a real shortage of doctors. It was a huge asset to us, and I do believe the amount of flu shots that were given quadrupled. I'm very interested in this bill. For that reason, I believe that it cut cost tremendously. I guess my biggest concern, not being a pharmacist or a doctor, when I look at these medications, these injections, I don't have a clue how much they affect somebody. I wish somebody in this room would bring it down on my level so I could understand it and give me an example exactly, just some example of when this would happen and how it would come to fruition in the place that this passed.
I am not that I mean, I'm not a pharmacist. I'm not a physician. If you want to talk to somebody after the fact, my druggist sits in front of you there. But I expect the folks that come after me will probably be better able to articulate the actual. I can't. I'd love to be able to help you, but I don't.
Okay, we have one last questions, and then what I'm going to do, since Senator Unterman, are you still here? She's right outside. I'm going to stop before we hear from people from the audience. She has a bill, and as respect to my counterpart in the Senate, which should not take the length of time that we will have with people talking, I'm going to stop. We're going to take that bill, and then we'll go back to people from the audience speaking. Representative Watson. This is the last one.
Yeah, and just for Representative Pack, and who came in a little bit late, and our discussion has not really been about scope of practice or reimbursement from that perspective. It's really been, and we've been pretty upfront with this, and Senator Bethel has been more of patient-centered medical home and getting patients into their primary care physician. Certainly, health departments, have protocols and PAs, nurse practitioners, and do administer vaccines. And certainly, if something does go wrong, they're there to help out. And presumably, with a flu shot, the pharmacist, doesn't have ACLS, I don't think, but has some kind of, I guess, defibrillator or whatever, related to that. But I will tell you, the quality is what, from my perspective, is not a monetary issue, though I will disagree with you. I think it's a monetary issue from the pharmacy standpoint. But I think from a monetary issue, from a physician standpoint, this is not what drives the angst related to this. I think it is more of a quality issue. And I think just my simple survey, and I think you'll see the ACP feels the same way. I think that entering things into the grid system, I think communication, I think is ever so important, and that's, to me, is not what's happening. On a personal note, I mean, I got several calls last flu season, just a few months ago, weeks ago, really. When the patient got the flu shot in the pharmacy, and I get the call in the middle of the night, my arm's hurting or I don't feel good, and that sometimes doesn't sit very well, and it's not my patient. They are not even sure what they had and whether they're allergic to eggs or whatever. So I mean, it's just sometimes it is trying, but it's not. It is, from my perspective at least, it is not a scope of practice. It is not a reimbursement issue that we've belabored already, I think, ad nauseum. We probably will belabor that point more. Thank you.
Okay. Senator Bethel, thank you very much.
Madam Chair, we spoke. I have
another meeting that you need to go to.
And I would love to be available to you and everybody, but I hope you won't take it as disrespect. I'm
No,
trying
sir.
to move House bills out. That's all I'm trying to do.
I won't. That's one of the reasons I'm stopping for a minute, and also out of respect for my counterpart who's been waiting. She got through with her meeting quicker than she thought, but unfortunately she was after we had started with you.
Thank you, Madam
Chair.
Chair.
Thank you very much. Okay, Senator Unterman, sorry.
Thank you. Thank you, Madam Chairman and members of the Health Committee. Thank you for hearing this bill today. I know that you're all tired, and I've been through the previous bill, and I know how exhausting it is. So.
And Senator, this is Senate Bill, what is wrong with me? Senate Bill 65 and LC 37151-9S. We got the right one?
I think you may have it, but I don't have it.
Oh.
I've got the original.
Oh. Here.
Thank you.
See that?
Thank you. Members of the committee, I worked on this the first week of session, and that seems like late years ago. I can't believe I worked on this, and it passed the Senate 51-2 at the very beginning of the session, and it was the very first week. And I'd like to present before you the Senate Bill 65, which adds licensed professional counselors to the list of people that are already licensed: physicians, psychologists, clinical social workers, and clinical nurse specialists that are allowed to perform emergency evaluations of folks who are potentially mentally ill or have alcohol or drug dependent problems. And this allows licensed counselors to be able to submit forms, what you commonly call the 1013 or the 2013 form, to be able to help these people and get them professional help expediently. And when I started working on this bill for the licensed professional counselors, it came to my attention of the dire needs in some certain parts of the state. And we have a map, and I'm going to just kind of use it for a minute and then I'll pass it around. There are several counties in the state of Georgia that do not have professional staff, mental health providers. And I understand that y'all had a meeting about ACT teams before this, and the Behavioral Health Caucus met before this meeting. So you know the transition that we're going with behavioral health and developmental disabilities and addiction diseases when we created that new department. But this map shows Eccles County, Bacon County, which is Alma, Georgia, Quitman, Webster, Marion, Barrow, Dade. Not the fact that they don't have licensed professional counselors, they don't have any mental health providers. And if you look at this, even in my county's 1 million people in Gwinnett County, they have 127 psychologists and they have 322 licensed counselors, but out of 1 million people, that is not many folks to provide services. But if you look at this, the urbanized area has mental health providers, and the only place, and Representative Kidd would be very interested in this, is Milledgeville in Baldwin County does have an anomaly where they have more mental health providers, and that's because of the historical perspective that they've always taken and taken care of people with mental health disease. So if you go down in some counties, a good example is Worth County has one. Clinch County, which is a huge county down on the border of Florida, has no has a clinical social worker, but that's it. Any place below the fall line and the NAT line from Macon on down is pretty much a deficit of not having any providers. Wilcox County has a social worker, and most of those are located in the DFACS offices of those particular counties. If you go up into the mountains, it's basically the same thing. So really only the urbanized areas have mental health providers. Oh, you have one? Oh, you may have one.
We do.
Why you don't tell me?
Oh.
I thought that was just fascinating, though, because I love mental health, and it's just fascinating to look at where these providers are. So basically, the objective of this bill is to expand that so that professional counselors can assist in issues related to mental health and get services. The question came up in the Senate, people that need help are going to eventually get help. It's the expediency. And with the tragic incidences we've had across the nation of people not getting the help when they need the help, that's what we're trying to transition in behavioral health, is that expediency. The only other issue that came up with this particular bill was the incidence of more admissions. And I'm of the opinion that if you're mentally ill, if you're going to commit suicide, if you need help, you have depression, if you're manic, that you're eventually, you're going to get the help. It's your initial contact with that professional, whether it's a social worker, a psychologist, psychiatrist, whatever it is. But it's that expediency that matters. And what came up with the transportation has always been an issue. Whether you're delivering Meals on Wheels or whatever you're doing, it's an issue in the state of Georgia. So the issue is who is going to take the person for the admission or the evaluation to a facility. And usually, if it is the sheriff's department, that is the age-old complaint down here, is that they spend their time, an hour in one direction or 2 hours to Milledgeville, wherever they're going, and then they have to wait on the person and turn around and go back home, so it's a 4-hour ordeal, whatever. So I understand that. If you look at statistics across the nation and where counselors are active and social workers, you're not going to see an uptick statistically. That's what they show across the nation. And I understand that the Sheriff's Association has reservations that if you add more professionals, you're going to get more people and more admissions. I kind of disagree with that theory. I think if you're sick, you're sick. If you're going to get help, you're going to get help. If you're not going to get help, you're not going to get help. But I am willing to amend the bill that puts in, and the chairman and I talked about this, a provision to look at those statistics and see if there is an uptick, and to evaluate who is taking these folks to these facilities. And I'm willing to do that because I think there's a lot of people out there that need help. And I'm willing to amend the bill and put that sunset provision in. I think it would be applicable if you could put 2 years from the actual begin date of the legislation from July 2013 and look at the statistics and put a sunset provision in there. And I'm agreeable to that.
Questions for the senator? I have one, just a statement. One of the reasons that you're bringing this bill, Senator, is because we are under a federal agreement, and one of the agreements is that we pretty much have to get people who are in crisis to help within 1 hour's time.
Yes.
And in southwest Georgia,
Yes.
We don't have anybody to set up these ACT teams that will allow a call to come in, someone to go see that patient and talk to them and have them getting help within an hour's time, and this would help correct that.
Yes, ma'am, you're exactly right. The Behavioral Health Department, if you do not know, is under 3 decisions, federal decisions, against the state of Georgia, to the point of levying fines on a daily basis if we don't adhere to certain provisions. And to me, this is a good example of trying to adhere to those provisions and also putting money into the budget.
Representative Hawkins.
Senator, let me get this straight. You're having a little pushback from the Sheriff's Department on this?
Well, actually, in the Senate, no one testified against this bill, but I have been talking to the Sheriff's Department, and over the years, historically, they have had this as one of their top priorities of transportation being an issue, because you're taking manpower out of the field of, going and doing their accident investigations, running their jails, whatever. And I think Terry Norris is here, and he's going to speak on the bill. And this is a concession to them it's not necessarily one I like. I think that's their job.
Right.
And I'm not going to go into my spiel, but I'm agreeable to that, and I'll be back in 2 years after that sun sets up, because I believe those statistics are going to show that these people need help, and you got to get them there. And the Sheriff's Department, that is their fiduciary responsibility to get them there.
Yeah, well, I think you got a good bill.
Thank you.
Representative Watson.
Just for my education, and maybe people that are going to testify can help us with this, but from the educational level of a licensed professional counselor, and to be honest with you, does the licensed clinical social worker, does she have a master's in social worker, and I'm ignorant on the subject.
Well, it's my understanding that if you're a licensed professional counselor, you have a master's degree. You go through an internship, and just like you do with a nurse or a practitioner, period of time. And to me, they are equal. I'm a social worker myself, and I would feel comfortable evaluating and submitting. And usually, the thing that people really don't understand is most of these counselors, psychologists, social workers, whatever, it's not the person's initial mental health problem. A lot of times, and they can correct me if I'm wrong, but it's my understanding, people have a long-term illness, and if the mental illness is not just a sudden thing where you just show up at a counselor's office and say, I'm depressed, I need help. Usually they're under the care of a psychologist, a psychiatrist. They've had an intervention in an emergency room. They have been within the mental health system before they're committed.
Okay.
And I'm sure they'll correct me if I'm wrong.
Is that it, Representative Watson?
Yes.
Okay, Representative Barr.
Okay, that was my question.
Okay, all right. Since the sheriff has been, Mr.
And
Norris has
I
been.
do have, I had some folks from Grady Hospital, and they had to go back to work.
Okay.
So but they were here, and they were in favor of the bill, and they worked in the emergency room, and they've gone back to the emergency room at Grady.
Okay, thank you.
I believe there are some counselors here.
There are. Some,
Thank you.
Senator, you're not leaving yet, are you?
No.
Okay, that's all right. You can. Okay, all right. Hopefully it won't take that long. Terry Norris. Either one. Just it's quicker right there, probably.
It's got to speak, right? Madam Chair, I'd rather get a flu shot from my barber to have to come in here and express our opposition to this bill. But I'm going to oppose the bill. I'm Terry Norris. I'm Executive Director of the Georgia Sheriff's Association. I've been in this position since 1995, and this was absolutely one of the first issues that I confronted the first year in '96 in working with the sheriffs. The sheriffs are absolutely been the default on the transportations in this state of mentally patients in need of mental treatment or mental evaluation for all the years. And they're not here. They didn't send me here today to tell you they didn't want to do it. What they did send me to tell you today is that the last year that we have any real data, sheriffs, as you know, all work independently. There is no centralized clearinghouse of data and information on or performance data on the things they do. So occasionally we ask. And in 09 and 10, sheriffs in this state provided transport over 18,000 times. Now, our mental health system in our state is challenged, to say the best. We are now in a new era. We have a new commissioner. Not speaking anything negatively about previous commissioners. We are highly optimistic that we're going to have a delivery system for mental health services in this state that's going to accommodate the need. But I can tell you our ability to transport is challenged. Now, we don't have any empirical data that says that allowing our friends, and they are our friends, the licensed professional counselors, we don't have any data that shows that it'll definitely make the numbers go up. But we've always feared that. I mean, that's been our conventional wisdom. The more people that do it, likely the more 1013s we have. If that's wrong, we'll know in a couple of years if this bill passes. Nonetheless, your sheriffs are not here to say they don't want to do it. They will do it. But I can promise you, we have crisscrossed this state in the years that I've been here. Deputy sheriffs have traveled not thousands, but millions, over 1 million miles, taking folks back and forth across the state. And many times we would, and it's gotten better under Frank Berry's leadership, but many times we'll travel 3 hours with a poor person that's not only mentally unstable, but physically. They've got physical problems. We got them in the back seat of a patrol car with 250,000 miles on the car, and we're taking a 3-hour one-way trip. And for years, we've gotten to where we were told to take them, to be told that there's no room here. You have to take them somewhere else. So I'm not here to whine and complain. I am here to say that the sheriffs are going to do whatever y'all want us to do. But y'all, this is a challenge for us. And truly, it's not a humane manner to carry these folks. A lot of times, truth be told, a lot of times, not a lot of times, sometimes, we have to fight them to get them in the car. We have to fight them to get them out of the car. A deputy gets hurt. A patient gets hurt. That's not an everyday occurrence, but that happens. But we want to do what we're supposed to do to facilitate whatever it is y'all decide's best policy for our state. But I'm just telling you now, this whole mental health transport thing is not a new phenomenon, and it's not a new problem, and it's not going away. So, y'all, any questions, Madam Chair? I'd love to answer them. But
Questions for Mr. Norris? Representative Hawkins. Okay.
I'm trying to get this straight with your answer. I mean, you acknowledge that it's a problem, and you acknowledge that you're fighting folks, getting them in and out. So I don't know who else would do this other than a peace officer. Is that correct?
in those cases, yes.
Okay.
Absolutely.
So do you have an alternative solution? I mean, are you proposing something that's going to help? Because we know we got the problem.
We believe this is a state responsibility that sheriffs have traditionally taken upon themselves because the law, I mean, there's nobody else to do it.
Right.
We're not trying to get out of it.
No, I understand. I'm just looking for a solution because we got the problem. We got to have a solution. Right now, you're the only thing in sight.
New cars, more money, more officers?
Well, but we,
I
know, yeah, I guess, but, we don't, there are no state dollars.
Right.
For this. These are local tax dollars that pay for these transports.
Right.
So the solution is to continue this dialogue we've got. The solution is, again, we're proud to have this relationship with the counselors, and they may be right. Senator may be right. This may fix a lot of things.
Right. And you may be more proud after this, too.
We may be. And I hope we come back and say, good God, we wish we'd have done this in '96.
Great.
But,
okay.
But I guess more than anything else, Representative, we're concerned about the consequence. We don't know, and I don't think really anybody does.
So we'll try it.
I guess we will if this committee so chooses.
Thank you.
Thank you.
Okay. Thank you.
Thank you.
Are all these questions, Representative Kidd, are they for? Okay.
Terry, just one quick question. Of course, it looks like you had a reaction to the vaccine you got. If you're talking about your haircut or something.
Yes, sir. That's by design, sir.
But,
Watch it. You just violated HIPAA.
I mean, obviously support the legislation, and obviously my sheriff is, best friend of mine and so forth, and he complains to me about the driving all the time and how much it costs the county taxpayers and so forth. Isn't one of the problems today, more so than a year ago, that there are fewer places to take the patient today than it was years ago, so you have to drive further?
There are fewer defined places at this time. There are fewer hospitals. There are fewer hospital beds.
Right.
Again, that's part of the system of the delivery of mental health services. I think we're headed to. We're not there yet.
Follow-up question: as we implement this, and the facts and figures show what it really is, would it not possibly benefit through the appropriations process and the lady who sponsored the bill potentially coming back and helping to reimburse the counties for some of the travel you have to do, like we reimburse the counties now $14 million for housing state inmates?
Yes, sir, that certainly would be helpful, and we have talked about it a lot of times internally. In the figure I gave you a while ago in 09/10, there was just under 18,000 transports, and those were reported by 126 counties. Not all the sheriffs reported. That was a cost of about, based on their estimates, and it was really a rough estimate of about $1.7 million.
Thank you, sir.
Thank you for the question.
Representative Hadgett?
Aren't there private companies, though, that do transport some of these mental patients?
There are. It is the responsibility of county government to make this happen. And the sheriff is the default or the only person at the county level with that statewide authority and traditionally has done that. I have been told, and this may not be true, that the reason the sheriff started doing it to begin with, because they were the only ones in the county. Providers becomes established throughout the state. I think we're going to be faced with the same dilemma that we're in now.
So, I mean, but what you're saying is the department's really working on this and trying to streamline it, and I can see the senator nodding her head, so I'm glad to hear.
Thank you very much to everyone who came to testify. Thank you. Thank you very much, Senator, for waiting and presenting the bill. Okay. To the committee, rather than take a 5-minute break, if you need to take a break, just get up and leave, and please come back. So, stretch your legs, whatever. No, it's a hearing. It was a hearing. But we have people who come to testify, so it is important that we hear them. So if you need to go out and get a drink of water, stand up and stretch your legs, fine. Okay. I'm going to ask the people that are presenting to limit it to 5 minutes. I'm going to ask Sarah to give you a warning with a sign. If not, we will be here till 7 or 8 o'clock at night because I want the committee, if they have a question, to be able to ask you. And I am going to start off with Dr. Mandy Reese. If you'll tell us who you are. Why don't you stand? I think it's quicker. People get comfortable in those chairs.
Yes.
Tell us, you are a doctor of what, and your name and all, and we'll go from there.
Yes, ma'am. I have my Doctor of Pharmacy degree. I'm board certified in advanced diabetes management. I'm a certified diabetes educator. I come today, and I appreciate your time and attention today. I am a professor in a college of pharmacy as well as a practitioner. I'm coming not representing anyone but myself and to share my own viewpoints today. What I would like to start off with is talking about access to care. I have a packet of information that I've put together for you all. And I want to start with a study from the Urban Institute researchers. They found that tens of millions of adults under the age of 65, both with insurance and those without, saw that their access to health care worsened dramatically over the past decade. The findings suggest that more privately insured Americans are delaying treatment because of rising out-of-pocket costs, while safety net programs for the poor and uninsured are failing to keep up with the demand of care. Also, the first, and I've labeled the documentation for you. Documentation A has statistics from the CDC website that I actually pulled today. There was a question about the percentage of adult vaccinations, and if you look here, specifically if you go to pneumococcal and you go 18 to 64, HR stands for high risk. Only 32.8% of folks are getting vaccinated. This is from the National Immunization Survey. This is the most recent data I could find. Also, I want to point out, Ma'am,
For Georgia
this is national statistics.
Okay, do you have Georgia
I
statistics?
do not have Georgia statistics. And then 65 and older, which largely affects pneumococcal, about 65.6% of folks are vaccinated. If we move down to the tetanus in the past 10 years, folks 18 to 49, that's 57.2% have been vaccinated. And if we move to 65 and older, only 44.1% have been vaccinated. Now, I want to point out here, pertussis was mentioned earlier. Tdap is the vaccine for that. That has become a prevalence and importance because the increased numbers of pertussis in children. Adults serve as the reservoir for pertussis. So if adults get vaccinated, we protect children. And that's been the big push with the Tdap specifically. Now, if we go on to evidence B, that is a pie chart specifically for pneumococcal vaccine that says of all folks that have an indication for this particular vaccine, 70 million folks continue to be unvaccinated. My point there is that there's a need. We do have a need, and that's my evidence for that. And so access to care is an issue. These stats point to that. Evidence C, and again, I don't have the specifics, Madam Chairman, on the states that use protocols, the specifics of what the intricacies of which vaccines, but I just wanted to point to the fact that there are states that pharmacists work under a protocol with a physician. So wanted to point out that that did exist. Several times during the discussion today, we've talked about this current protocol for the influenza, and I have labeled that as D in your packet. That goes over the intricacies of the protocol that we currently have for influenza. A few things I've highlighted for you, I've underlined them and pointed to them. Just some things I wanted to talk about, because I remember last year when I testified, we talked about the big concern about patient safety. If there is an emergency, what are we going to do? A couple of things in the protocol here. One is, in order to immunize, you have to have epinephrine on hand. You cannot vaccinate if there's not epinephrine. Second, the appendix to this protocol has a detailed outline. If there isn't a medical emergency, what do you do? So it is outlined clearly here what you do. So I wanted to point that out. And lastly, what I would like to point out is evidence E and F. I'm getting excited here. I've been training pharmacists for the last 10 years on how to give immunizations. It's offered by the American Pharmacists Association. It's a certificate training program, 8 hours at home, 10 hours live. We do a vaccine checkoff to make sure that they do know what they're doing. In closing, I want to say this is about access to care. It seems like, in all due respect, we've chased some bunny rabbits today. And this is, I've worked in public health. I know the needs of public health, and I want to encourage you, this is a vote for your patients back in your district. This is about access to care, and that's what I wanted to share, and I appreciate your time.
Okay. Are there any questions for Dr. Reese?
And Madam Chairman, I did get data on if someone would like it, on the Federal Register, the cost savings when they did the TRICARE vaccine zero copay for the first 6 months. So I do have that data here if you would like me to share that.
I mean, I don't think it's relevant. You can share it if you want to, but many more people will get the flu vaccine that that should have all of the other vaccines. So that would be comparing apples to oranges, but you're welcome to share.
Certainly. Well, I'll just mention it briefly just because it had been mentioned earlier. And this is from their Federal Registrar dated July 2011. For the first 6 months following publication of the rule allowing pharmacies zero copay shots, 18,361 vaccines were administered with the pharmacy benefits plan at a cost of $298,513. Had these vaccines been administered under the medical benefit, the cost to TRICARE would have been $1.8 million. The big cost savings there is that you're running it under a pharmacy benefit program versus a medical benefit program. And again, I just wanted to share this. This is just data from that. It's not Georgia specific, so just wanted to throw that out there because someone had asked the question.
Representative Watkins.
So this is the data that Senator Bethel's been quoting?
Yes, sir.
Okay, and so that really basically could be solved by reducing the reimbursement to physicians.
Technically, that is one possible solution. Yeah, certainly.
So that really has nothing to do with price then, because the wellness visit and the TRICARE visit and the copay is zero. So okay, well I'm glad you brought that up.
Just FYI, because the question had been there, but that wasn't relative to the points that I was bringing up.
Thank you very much.
Yes, ma'am.
Okay, let's see. I will try to go back and forth on this. Marcus Downs. Okay. Are you introducing the person you listed below, or are you speaking, both of you speaking?
I'd like to take maybe 2 minutes to just explain Mag's position, then introduce the
Okay,
guest.
I'll give you, you've got 5, each of you have, okay, just go.
We will both take our 5 then.
Okay.
Madam Chair and members of the committee, my name is Marcus Downs. I represent the Medical Association of Georgia. I don't want to repeat any of the points that have been raised, but I do want to make sure I've been very explicit about MAG's opposition. This is not a scope of practice fight. Every representative that I've spoken with, I've made that very clear. This is not about a turf war. This is about patient safety. This is about sacrificing care over the professional education and expertise of various individuals. MAG represents over 7,000 individuals who practice medicine in the state. According to the Georgia Physician Workforce Board, there are just over 16,000 active physicians who practice. So MAG represents roughly half of the physicians in the state. Additionally, at MAG's most recent House of Delegates last September, where we actually have attendees who represent every facet of medicine from all across the state. There are over 300 attendees who attended. This is one of the questions that we put to those individuals who represent all the specialties, and nearly 70% indicated that they were opposed to the expansion under a blanket protocol. I will say that we have gone on record indicating that this does interrupt the patient-centered medical home. I do have some studies from CDC that I would like to reference. I can show you 25 studies where we agree, and I want to say that we strongly agree with the need for more adults to be vaccinated. We couldn't agree with that more. It would be great if it could be done at a less expensive cost. But one of the things that we contend is that there are no studies, that the literature is void on anything that says adults are not getting vaccinated because of geographical access. There are also no studies that say that adults are not getting vaccinated because of cost. We believe that the bill is very well intended, but you've got to get to the root cause analysis. I can tell you that in one of the increasing adult vaccination rates in terms of what works that's published by the CDC, it references standing orders, which is something that's been referenced here earlier today. And what it has to say about standing orders is the advantage is the standing order is the most consistently effective method for increasing adult vaccination rates and it's the easiest to implement. However, the big disadvantage that CDC itself highlights is that standing orders only reach patients already contacting their public health system or their health care system. What we believe this bill says, essential, not what it says, but what will happen as a result, an unintended consequence, is individuals who are already receiving their vaccines, be it at their physician's office, be it at the health department, if they're going to the pharmacy under prescription or their pharmacy under protocol, those individuals will continue to receive their vaccines. What the bill does not tend to accomplish, and I mean no disrespect to Senator Bethel, is it does not address new patients. It does not address those individuals who are currently not getting vaccinated. This is a matter of health behavior, health attitudes, looking at norms, and you have to break into that in order to really increase the vaccination rate. Additionally, what CDC says are the appropriate settings for vaccine administrations are private practice, managed care, hospitals including ERs, and long-term care facilities. What I would highlight there is that in no venue is a pharmacy ever referenced as an appropriate setting for vaccine administration. We concede that vaccines are a lot safer today than they were 10 years ago. They're a lot safer than they were 5 years ago. So as you've heard, individuals have said that last year the argument was about adverse events. And I can actually highlight a couple of adverse events where flu vaccine administration has required surgery to rotator cuffs because of improper administration, be it based on intramuscular versus subcutaneous. These are all things that we actually can verify. I'll take any questions. I know that time.
Dr. Hall, you might want to sit down because I said I was going to go back and forth between people. I didn't want you to have to stand there for forever. I'll take a pharmacy person and then go back and forth. Questions for Mr. Marcus? So you're saying that you can actually document adverse situations that have occurred. I've had rotator cuff surgery. It's not pleasant. So there are cases on record to Representative Pack's question before that where there have been problems.
And I would be happy to forward that to you either now or to your staff.
Like that.
I would, just for future introduction, we have Dr. Angela Hall. I know she's not going to speak right now, but Dr. Hall is board certified as a pharmacist and as a physician, and she'll speak at a later time.
Okay. Thank you. No other questions. Thank you very much. Okay, Lisa Chapman with the Georgia Pharmacy Association.
Good afternoon. I'd just like to say, Madam Chair, thank you for allowing us to have this opportunity today. Again, my name is Liza Chapman. I'm a registered pharmacist and practicing pharmacist in the state of Georgia, and I'm a community pharmacist working currently for Kroger Pharmacy. And so I know there have been some questions about how the standard of care and how immunization delivery is practiced in our state. So I'd be happy to entertain any questions today, but just want to give you some feedback from the pharmacists that I work with on a daily basis because I am responsible for their training. It is now standard care or standard education for all colleges of pharmacy in the state of Georgia to provide the immunization training for our student pharmacists while they're in pharmacy school. So just to make that point that this is now part of community practice and also other practices of pharmacy throughout not only the state of Georgia, but throughout our nation. We have talked about accessibility, ability to provide services in our pharmacies, but just to give you an everyday experience, real-world experience. So if someone came into our pharmacy and they had a prescription, say for herpes zoster, Zostavax prescription from their physician, how we would approach that is we would treat that as any other prescription in our workflow. So the patient would present that to the pharmacy counter. We would have our pharmacy technician or student pharmacist address that patient, give them the necessary paperwork, our vaccine administration record form that we would go through individually with that patient to identify any contraindications to receiving that vaccine. So it is a very step-wide process. We don't rush through any, we do take our time. Say if a patient did not want to wait the 30 minutes, we would ask them to come back at a slower time when they could receive their vaccine. But we do go through a step-by-step process to make sure, and for the protection of that patient, to ensure that there are no contraindications to receiving the vaccine. Only pharmacists in our practice are administering, so I just want that to be clear as well, that some folks do ask the question, well, are your pharmacy technicians or clerks administering vaccines? And no, it is only the registered pharmacists. And we sit down and we talk with the patient about the risk and the benefits of receiving that vaccine. We do provide a vaccine information statement. We are required by federal law to present that statement to the patient because that is a requirement. And that lists all the benefits and risk of receiving that vaccine for the patient. If the patient does meet all the requirements, we vaccinate, and then we instruct the patient that they need to remain in our pharmacies for 20 minutes per CDC guidelines to make sure if they were to have an anaphylactic reaction or any type of reaction, we could take care of them. Because pharmacists, after going through all of our certificate training that Dr. Reese spoke of, we are trained in healthcare provider CPR, and we would be able to administer CPR, call 911, administer epinephrine per our standing protocol agreement. So in my 10 years of practice, I have never had a patient that has had an anaphylactic reaction, but I have felt confident in my practice and my training that if something were to occur, I could handle that situation. And again, I know that we have talked about lots of issues today, but this is a public health concern and about the accessibility of care, and it's about providing good patient care to our patients. We want to work with physicians. If a patient asks us to fax a copy of their administration record form to their physician, we do that. And in our practice setting, we also report to the Georgia Immunization Registry and Transaction Services every week on a weekly basis. We have a data feed that all the vaccines that we administer are reported to the registry. So I'd be happy to answer any questions if anyone has specific questions about the administration of vaccines in pharmacies.
Well, I don't have one about the administration of vaccines, but I want to know where you work.
I work for Kroger.
No, I know. Which one?
Actually, I'm our division clinical coordinator.
Oh, well, because, you know, I get my medicines from Kroger's, and I love my Kroger pharmacy, but if I call it in, I'm told I have to, you know, I call it in at 9:30 in the morning, they tell me I can't pick it up before 1. And my last 2 visits to my Kroger pharmacy, I have waited in line over 30 minutes with each time 7 or 8 people behind me waiting just to get medication. So I was hoping that you worked at one where you had time to sit down and do all of that, because that's where I was going to go, even if I had to drive across town. Representative Henson.
I think you just stole my speech.
Oh, so I'm sorry. It's just what I run into.
No, I mean, and it's
I love
like
my
a Kroger.
pharmacist.
It's like Walgreens. I was told to come back at 6:45. I mean, beside the fact there are 4 cars ahead of me in the drive-thru, 3 cars in back, people inside. So I sent someone over 45 minutes after it was promised. It took him an hour to get back to my house, and I could walk there. It's 5 blocks away, and it was because everything was so backed up. And this isn't just about this, but it's also about the whole thing of the pharmacist being able to talk to the patient. You know, are you familiar with this medicine? Are you this? Are you that? And most of the pharmacies I see, you don't have that room to sit. You don't have the room for privacy. You don't have that space to talk to your patients. Like a CVS I go to, really, the 2 chairs that you could sit in, people are always sitting and waiting for something. And there aren't other spaces, you know. I guess I grew up with pharmacies. They had counters and they had little tables. The pharmacists could really sit down. And I don't think we're allocating enough space to pharmacies within the big pharmacies, you know, the Walgreens, CVS's, and then we'll go to the Kroger's and all the rest of them. That's all.
Okay. I will say at my Kroger's, they've just remodeled, and they did get a room that was separate, and I waited closer to 45 minutes when my pharmacist was giving 2 injections to a couple, and he did fill out the forms, and he did, you know, I don't know that he put it in the grid because I didn't sit there and watch.
Well, he does it. I'll just let you know, we have a data feed, so the pharmacist doesn't have to take time to that. We have someone on our IT department that pulls the data and enters it into grids.
So
we have the fortunate ability to do that.
But the waiting problem is in the metro areas, I think, a realistic problem and one of the concerns. Thank you very much.
Yes, ma'am. Thank you for allowing me to explain the process.
Dr. Hall.
Put this up a little bit here. Thank you, Madam Chairman, for letting me speak today. Again, my name is Dr. Angela Hall. I'm a board-certified pediatrician, and I'm a board-certified pharmacist. What's different for me is I worked retail for 3 years before I went to med school. I worked in one of the major retail pharmacies where you do 400 plus prescriptions a day, where you're doing the window, you're doing the phones, you're answering calls, you're doing patient counseling. I've been on that end. I'm also a pediatrician that owns her own practice, a solo practitioner. So I'm well aware of vaccines, which I agree with Representative Watson. You don't make money. That is not the reason for this at all. Actually, it's going up. I'm the one to do the costs on my vaccines. So I have both aspects of the coin. We're trying to keep primary care at the doctor's office. I have patients that don't come in unless they need vaccines. That is our only opportunity to provide preventive care for our patients. If we're giving vaccines at all these different avenues at the pharmacies, then we don't see those patients come in. So my young man who is 18 years old is going off to college. He's coming in to see me to get his Tdap or his Menatra for to go to school. How about his blood pressure is a little bit elevated? We end up sending him to the renal specialist. He has borderline hypertension. If I never see that young man and he doesn't go to the doctor until he's like 25, 26, he can potentially be in renal failure or be very hypertensive. What is important about this bill, which I disagree about, and being a pharmacist too, is one-time restraints. You must keep up. Grits and storing vaccinations is so important. You all, influenza vaccine, that's minor compared to having multiple vaccines you give. We have to keep temperature logs. There's some diluent in vaccines you have to combine to give to the patient. You have to know what you're doing. In addition to, I disagree for people to give, as a pharmacist, to give a vaccine and you don't even know the disease. Sometimes when you give MMR and varicella, guess what? The child or the young adolescent comes back with a rash. I know what that rash is. It's the interaction between the two vaccines. If someone who's never practiced medicine gives that, they'll be freaking out. They come in with the swelling of the arms. When they call me at night, I know exactly what's going on. But when you all go from this place to pharmacy to give the vaccines, then we don't know as primary health care doctors what's going on with our patients. And that's the only way we can get them in so we can do that education and find out what's going on. You're seeing a decrease in cost. You decrease in cost by coming to your primary care doctor, getting those vaccines, because we're able to avoid all these diabetes. I screen my kids for blood work, high blood pressure. All that is done at the well child check. It's just not about vaccines, because I promise you, as a business owner, I lose money on vaccines, but that is the only reason why I can get most of our patients in. And the reason why I'm passionate about this is, although you're looking at a bill that says 18 years and older, I have relatives that work in adjacent states who are pharmacists. They took an exam. It has 6-month-old and 9-year-old. So where are we going to go with this bill? It's going to get younger and younger, and then my kids are going to stop coming in. They're going to go into the pharmacies and get their shots, and I will not see them. So that little boy that I diagnosed with a renal tumor, I wouldn't have saw him unless he came in for his vaccine, and I palpated his belly. So the vaccines need to stay in the primary care physician's office and not in the pharmacy. That is not the place nor the time for to be able to do that.
Dr. Hall, wait, hold on a second. Are there questions for Dr. Hall? Thank you for your. Okay, thank you for your passion. Okay.
I'm not going to disagree with anything you're saying, but in terms of flu shots and such, now those are fine with the pharmacy, right?
I'm gonna
children.
Okay, let me just explain what my concern is.
Right.
We did a big push this year. Get your flu shot, get your flu shot.
Right.
We wanted everyone to get the flu shot, and most people could afford the $20 or $25, whatever the flu shot was.
Right.
But if they then go to a doctor and they don't have a regular doctor, then they're charged for an exam. A lot of these folks don't have insurance. They don't have the extra money for an exam. Yes, I agree, they should be getting exams, they should be going to a doctor and everything, but we have to sort of look at both of them.
But normally when those folks come in for their annual, there's no copay. There's no copay.
That's if they have insurance. I'm talking about the uninsured person who feels, let me get a flu shot, at least protect myself or protect others that are going to be around me.
Dealing with self-pay, that amount, that $25 they pay at the CVS, that's the same they will pay in my office. We would just charge them at cost. But we would have documentation of that in the office and any other issues that are going on with them. But if you do all these miscellaneous places, then we don't, the thing is we have duplication of vaccines. We even have that in peds, where they'll go somewhere, but we're able to put it in grits. As a pharmacist, they do not have the time. Our nurses put that in the system. They don't have the time to put that in the grid system, but there'll be duplication of vaccines given and errors given in vaccinations. So again, it's not more to the patient to go, less to go to the pharmacy. You still can do it at the doctor's office or the community health center.
Thank you. Thank you, Dr. Hall. Jonathan Marcus with the Georgia Pharmacy Association. And Dr. Juror, I'll get you next. Sorry, thank you for waiting.
Thank you, Madam Chairman, and the representatives. I'm Jonathan Marquis, community pharmacist in Marietta, Georgia. I own 6 pharmacies across the state and have been an immunizer since 1994. A lot of things have been said. I guess the one thing personally I like to say, I wish more Georgians could come in here and see how hard that each one of you work for the citizens, and I appreciate you listening to us today. I don't want to repeat anything that's been said. I agree. I came down here to talk about increasing access, increasing the vaccination rate, and decreasing the cost of health care. I work with dozens of physicians right now that call me and count on our services. I work with multiple health departments that count on us and even post our hours that we can help them maybe on Saturdays when we're open. I know some pharmacies are open Sunday. There was some statistics that were mentioned today that were actually not true, and I'm going to try to clear a little bit of that up, and I want to make sure the committee knows pharmacists do not want to give kids shot. We're actually doing very, very well in Georgia in pediatrics, and I appreciate that doctor saying that. We're doing an excellent job. We're doing horrible with the adults, and you can look this up all at the CDC on the BREFAS database. If you're wanting to have a healthy state, if you're wanting to follow the CDC Healthy People 2020 goals, we have a 90% rate that we're shooting for with flu. We're down about in the 60s with adults in Georgia. I speak to helping my patients in Marietta and Woodstock and Mableton and Athens that can't go see their doctor every season during the flu shot. We support going to see your doctor. Matter of fact, I've had countless letters from doctors thanking me for sending them over to get back into the doctor's office because maybe their cholesterol was high, or blood pressure was high, or their diabetes was out of shape. So that was a point. All 50 states, pharmacists can provide immunizations. After that, it does get very unclear, Madam Chairman, but I will tell you, June of 2012, 41 states can administer all vaccinations. Now, it gets a little cloudy. Only 20, no questions asked, a doctor can sign a protocol, they can do all vaccines in 20.
Right.
All 50 can do them with a prescription. 41 can do them, some protocol, some not. 20 states can do it with a protocol.
Thank you for that. That's much more correct and much more factual to the legislators to say there's only 20 instead of what has been said over and over to us again, that 38 states allow people to do it. Thank you for being honest. But of course, you come from just the edge of my district in East Cobb, and you're one of the pharmacists that I know, and
Absolutely.
I would expect nothing less. Thank you.
Well, the one last thing that I will say, I was coming speaking for myself today, but I am the current chairman of the Georgia Immunization Coalition, and all these facts are up to date. You can check them online. Love to open it up to questions.
Okay. Are there questions for Mr. Marcus? Okay. You have a question? No? Okay. Representative Watkins.
Thank you, Madam Chair. I just want to applaud you for coming and being straightforward, and you're the kind of pharmacist that we enjoy working with in conjunction. I mean, it is, the bottom line is quality care and getting people immunized. Thank you for coming.
That's a great partnership.
Jonathan, we met last year and talked about this bill.
Yes, ma'am.
And one of my concerns was the problem with the pharmacist and the retail pharmacies being so hassled and so busy all the time. And at that time, is it not correct that you told me that you also had concerns with several of the big pharmacies?
Well, I will say this. I come here that say pharmacists are highly trained. Since 2000, all pharmacists are doctors. I'm a doctor of pharmacy. There's doctors of medicine. There's other doctors. I'm concerned about any pharmacy that's not highly trained, that does not follow the guidelines, does not ask the screening questions that we ask everybody, and over 2,000 shots that we gave, every single one of them was entered in grit. So I don't support anybody that doesn't follow those guidelines. The pharmacies you're talking about, certainly, they're my ardent, competitors. But I have to take my hat off to some of them that have done a good job, remodeled their pharmacy, have private areas like we do. I think it goes back to, I don't think a physician would enter in an agreement with me if he or she didn't know I was highly qualified. So I think that out there is the key. We can give the shots if a prescription comes in. If we work within a physician that we know, that we go to church with, that we go shopping with, that we play golf with, they know we're up to snuff. They know we are following the guidelines.
Well, and I think that my husband, a physician, would have no problem in doing what you say, and I bet Dr. Watson wouldn't, in entering to agreement with you. But this bill is a blanket agreement and covers pharmacists, in retail things that people don't know and the doctor doesn't know and doesn't have any relationship. Is that not correct in the bill? I mean, that way it is, if you haven't read it.
Yes, ma'am. I think the one thing I would say is I don't think there would be any physician that would get into an agreement with a pharmacist that he or she didn't know that was correctly providing immunizations.
Okay, I think there might be some that wouldn't know everybody and think that it would be okay in that kind of blanket statement. But thank you very much for coming, and thank you for the good job you do. And like I say, I don't think my husband would have any problem in doing that kind of an agreement with you. Thank you.
Thank you.
Okay. Go ahead.
Thank you, Madam Chair. I do want to say that I am an immunizing pharmacist. I do work for a large chain, and I can support that our protocols and our policies and procedures are exactly what is outlined here. And I can support that our pharmacy does enter into the GRIT system. I can tell you that I have given probably over 800 flu vaccines this last season, and that was working on a very limited basis. We are also under prescription administering Zostavax, the other vaccines, Tdap, pneumococcal, as prescribed. And I think there's a place for it for those people who are underserved, who do not have a medical home. And I think any pharmacist would refer to the primary care physician in the event that there was anything that they questioned about that patient. In the interview and going through the VAR protocol.
Representative Broadwick, I don't think anything that I've asked or Dr. Watson asked in any way is questioning what you do. I think we, especially I do, live in an area where the pharmacies are very busy in these big retail pharmacies. They're usually, the one at Kroger's is usually staffed with one pharmacist and one tech. I have occasionally seen 2 techs and 1 pharmacist, but it's pretty rare. And I've seen them work their tails off and not stop for a minute.
I can tell you that that's what I
and the way, and and I heard when you were running for office that you were a very different kind of pharmacist and that I was going to really enjoy having you down here. So
I hope I still retain that.
You do, sir. Thank you very much. Okay, Dr. Doerr. You're welcome. It's true. It's what I heard.
Thank you for your time. My name is Dr. Emmett Doerr. I'm a board-certified internal medicine physician, and I chair the Health Policy Committee for the Georgia chapter of the American College of Physicians. And we are against this bill due to 3 areas of concern. One is fragmentation, which Dr. Watson and Dr. Hall have already spoken as eloquently as I could, so I'll skip over that. The second is patient safety, and the third is confidentiality. The issues of patient safety, I think, are largely in the area of live attenuated vaccines, such as Zostavax. These are live biological agents, and they're relatively or absolutely contraindicated in a whole series of conditions. In my practice, I've had multiple patients with transplants, kidney transplants, liver transplants, bone marrow transplants, on immunosuppressants. I had many patients with cancer on chemotherapy, many patients with lymphoproliferative disorders and leukemia, all of which these things are relatively or absolutely contraindicated. A lot of patients with HIV and AIDS, okay? Now, this bill does state that the pharmacist will require that the patient read a list of contraindications and sign off that they don't have any of these diseases. That to some extent is a level of safety if they go through that. But it may also frighten the patients. A lot of my patients who are very, very sick and have a lot of concerns about too much treatment might actually be scared by the statement that this is contraindicated when perhaps in their case it's relatively indicated. That's why I think it's important that physicians write an individual prescription for a lot of these different vaccines in different instances. Another issue is often there's duplication of vaccinations because of the inadequate records, even with the grid system. Some of my colleagues, in writing recently in the last 2 weeks, told us that even though they write prescriptions, they went and they looked back over the last month, how many of those were reported in the grid system, and there were very few. So with inadequate information, there can be duplication, and that's unnecessary or unfortunate. But I think the biggest patient safety issue ties into the fragmentation issue. We not only don't have enough Americans who are vaccinated, and I'll talk about adults, which is my specialty. We don't have enough people getting their blood pressure checked. We don't have enough people who are getting their cholesterol checked. People are still dying unnecessarily. And when patients came into my office, they could come in just to get a flu vaccine. But they also went through a nurse who looked at about 40 health indicators that we have on the record for that patient and would see if certain other things needed to be done. The blood pressure was checked. Those are the advantages of a more integrated primary care system, and they really have a lot to do with patient safety. So at a time when health insurance is expanding, when co-payments are being lifted for these things, I think this would further fragment things. The third issue we're concerned about is confidentiality. In the 5 or 6 pharmacies I'm familiar with, all in supermarkets, not one of them has a confidential place for the kind of counseling that people have been talking about to occur. So if one of my patients, who's relatively immunosuppressed, goes in and notes on here, on this list, that they have HIV, how are they going to talk about it when their neighbor Mabel is standing behind them? That's an issue. The pharmacies I've seen, from the standpoint of counseling, don't meet federal HIPAA requirements. In our offices, there are confidential rooms where nurses and doctors talk with patients. That's not the case in the pharmacies in Georgia for the most part. And that alone is reason enough, I think, not to pass this bill. So again, our concerns are patient safety. Our concerns are decreasing fragmentation, not increasing it at this time, and the importance of patient confidentiality. Thanks for your time.
You will tell us, well, I've got your name, but...
All right, my name is Elaine Smida. I'm a pharmacist licensed in Georgia, and most recent practice environment was for a large retail pharmacy chain. I do know Jonathan, and he has got an idyllic practice, and I do know that his expertise in pharmacy is well respected amongst us. I do, however, come with a different viewpoint. Being that I did work for the large chain and knowing, as many we talked about, the busy environment and the what I call the 5-ring circus, which includes the drive-through, includes the computers where we need to be focused for data entry verification, and electronic prescribing is coming into play now, so we're constantly being flooded with prescriptions coming through. There's also the phones that are ringing off the hook, generally questions from patients on prescriptions they'd picked up or over-the-counter questions. There's doctor calls for phone-in prescriptions. There's also the mandatory counseling with new prescriptions that has to be done. And there's also just people walking in that don't feel well and want to talk to the pharmacist. So all of this is happening. My personal experiences with understaffing, I have actually worked for almost 2 years in a situation where I only had a technician for half of my 8-hour shift. 4 of those hours I worked by myself. And now what we're doing is expanding to all of this. Even with just the influenza alone on protocol, it's been a challenge at best, and that's during the flu season. Generally, when people come in, that's where we're going to see more prescription volume, higher prescription volume. We're going to see people in there trying to get their medications before they leave for town, and this is happening November, December, January, whatnot. I will say that although personally I never had any adverse reactions occur from my immunizing, I do know my colleagues that have said there had been incidents. I was not there, but they had told me of instances of fainting that had happened. I also know of a colleague who, her first time ever giving a shingles vaccine, actually the needle went through and came out the other side, other end of the skin. I mean, there are significant pressures on a pharmacist in a retail setting, and I think we all are aware of that. I do have concerns too about a lot of the setups. And again, the idyllic situation is to be in an own separate room where it's private, where no one can overhear, where a patient is lying on has the ability to lie on a table, and the focus is only on that one particular patient while the immunization is occurring. That is not the practice model, the setups in the retail chain pharmacies particularly are talking about. And in Georgia, with Georgia law, pharmacy law, it is against the law for the pharmacist to actually leave the pharmacy area, the dispensing area, and to go to another room. It's not permissible unless, of course, there's another pharmacist that can take care of that while that pharmacist leaves and tends to the patient in a separate room. Legally, you cannot even go to the bathroom in the state of Georgia as a pharmacist without locking the pharmacy. And that I got from a Georgia Drug and Narcotics agent. So that is for fact. So unless the staffing ratios are such to allow for the proper administration of these vaccinations, I am very concerned. And I do see that influenza, I understood. I do understand that. But when you start expanding it this rapidly without thinking it through, without being, more intent on patient safety, and we mentioned patient privacy, I do happen to believe that this bill is kind of ahead of itself. There's lots more that needs to be thought through. I do have, I know a couple of questions came up about adverse reactions. I don't know if you're aware of what's called the Vaccine Adverse Event Reporting System. It's actually available for anybody to check. I actually went through it last night, and what you can do is actually pull up, I have here where I pulled it up based on the symptoms that occurred, and also with the vaccines, and they do match up. They are assigned numbers. One of the biggest things is going to be fainting after an immunization, and the practice pearl that I have discovered through my research is never to sit a patient at a table. Well, that's exactly where these vaccines are being administered in the chains. I can't speak for all, but they're being administered at a table, which is exactly what you do not want to do because of the risks of fainting. So, where I can't really speak for the nurses' role in this. I know at least the nurses have the advantage of taking a patient into a separate room, and I mentioned about the, what do you want to call that, like exam bed or whatnot. And then if they feel faint, they just lay down, put their feet up, and, take care of that patient properly. Currently, the only thing to do in a retail setting is to put them on a cold floor. And, it has happened. There was I know a colleague told me about an incident of fainting fainting, passing out, some kind of a medical emergency after a shingles vaccine. 911 had to be called. Another young, I want to say she was maybe 16 to 18, had gotten an influenza vaccine, passed out. And one other thing I wanted to mention as well is during the busy flu season in December, a colleague of mine told me, we were talking over a weekend, we both were off. She mentioned that she did not have a technician. She was very busy. Somebody came in, requested an influenza and a shingles vaccine, which of course she had a prescription for, the shingles, but the influenza is on the protocol. she was so rushed and busy that she actually got to the table, didn't remember which syringe had which medication in it. So, I mean, there are pitfalls to this. I'm of the people that are here in my profession, I am the unpopular one to say this, but I do believe this needs to be more well thought through. I do have another document, and it's probably old, but it does talk about various other states, and, you know, we do know some do allow, it ranges anywhere from the very, you know, tightly controlled to the very, you know, it varies. I will tell you that I know for a fact Tennessee only allows influenza and pneumonia on protocol.
Ms. Murray, we need to draw it to a close.
Oh, okay.
On your
Well,
time.
just to say the surrounding states, South Carolina, influenza, pneumonia. Yeah.
We know them.
Okay, okay.
Okay,
right.
where did you get the vaccine adverse reactions?
It's the VAERS, Vaccine Adverse Event Reporting System. And it's actually like a database. You just need to agree. When you click on it, there's something you need to agree with. It's a statement, and it does say that not necessarily all of these are due to the vaccination. It could be from other, you know, but again, my other concern too is when you are expanding the protocol and you are getting into the live vaccines, as a couple of the physicians mentioned, unless you have a pharmacist on call, scratch that. Unless you had a medical physician or whatnot on call to be able to handle an event that happened after that wait time. Okay, there is, I believe the bill says 15 minutes for the influenza protocol, but 20, I think, was mentioned for CDC. And, you know, we have a fast food mentality right now going on with retail pharmacy, with the drive-through coming into play, that 15 minutes or less is basically what, you know, retail pharmacists are expected to get prescription out the door. But when you're dealing with hamburgers, fries, and shakes, that's fine. But when you're dealing with people's lives and a very serious potential, you know, contraindication is missed, I mean, we're talking about someone's life. So the fast food mentality is what frightens me. And, you know, even though everybody knows it's on paper, they don't want to necessarily follow that guideline and feel like they just walk out the door and everything will be fine. So,
Thank you. Are
I'm
there
sorry.
any questions for Ms. Smiley? And I will say, you talk about fainting. It doesn't sound very serious, but if you faint and hit the floor, like Dr. Burke, like Senator Burke did yesterday, and then has a small concussion and had to go to the emergency room, it can be serious. Thank you. You have no questions. Thank you very much. I will thank the committee members that waited until the last and listened to this. Thank you so very much for your attention. Thanks to everybody who came to testify. Thank you very much. We are adjourned.